Good afternoon, everyone. I'm Rhonda Anderson. I'm one of the level 4 instructors, and I'm going to be talking to you on managing increased intracranial pressure. So if you will hold on while I share my screen, we will start the presentation. So intracranial pressure, this is based on the 3 types of tissue that are contained within the skull. 78% of that's going to be your neurons, your brain tissue itself. 12% is the blood within the brain circulation, and the cerebrospinal fluid, or CSF, makes up about 10%. Now, when you look at this picture, if you think of your skull as an enclosed box, it can't expand, those bones are hard covering, and all those tissues inside being very soft, there's not much space to have an increase in any of those tissues. So if you think of it as a box, we've got the box stuffed as just about as tightly as we can. So when we talk about intracranial pressure, we're talking about how the pressure can change based on changes within that enclosed vault when any increase in volume of any of these tissues change. So we really refer to the Monroe-Kelly doctrine, and some of you may have heard this. And basically what this says is that the 3 components, the brain tissue, the blood, and the CSF, must remain at a relatively constant volume within the closed structure or the skull. Under any circumstances, if any of these 3 components increase within that cranial vault, the volume from another component has to be displaced in order for the total intracranial volume not to change. So, for instance, if there's an increase in brain tissue, then to maintain the intracranial pressure within a normal level, one of those volumes has to be diminished. So you may have decreased blood flow, or you may have extra reabsorption of CSF so as to maintain a normal intracranial pressure. However, the other thing that you have to remember is also the rate of which there is an increase, because the body does have some adaptability. If these are changes that happen over a slower period of time, it gives the body time to adapt. ICP may still go up, but it may be later on before we see signs and symptoms in a patient. If another component cannot or will not displace, then we have an increase in our ICP. The Monroe-Kelly doctrine is only applicable in situations where the skull is closed. So it's not valid in the neonatal population because their foramens have not closed. They're little soft spots. The anterior usually closes within 18 months. The posterior usually closes within about 6 to 8 months. It's not going to be valid in adults with displaced skull fractures where there's an opening or communication between the inside of the skull and the environment. Obviously, that's not going to be good, but that doesn't apply. Or if patients undergo a hemicraniotomy, where we actually remove a part of the skull to allow the brain to swell. And we'll talk about that a little bit later. So that's where your Monroe-Kelly doctrine is coming in. So what's normal? ICP under normal circumstances is relatively constant, and it's usually 5 to 15 millimeters of mercury. Now, obviously, this may change with patient position. So if I stand up, my ICP might be lower. It might be 0 to 5, okay? But in day in, day out basis, normal is going to be 5 to 15. Now, if I cough or sneeze or increase my intrathoracic or intra-abdominal pressure, then that can also raise my ICP. But it is a hydrostatic force, and it is a pressure that we can measure inside the cerebrospinal fluid compartment in the ventricular circulation. So factors that influence ICP under normal circumstances Any change in your arterial or venous pressure. As long as your mean arterial pressure stays between 70 and 150 millimeters of mercury, the arteries and the veins will vasodilate or vasoconstrict depending on how much blood flow we need through the brain at that particular time. So it can adapt, but once the mean arterial blood pressure falls below 70 or goes above 150, then we lose that ability to do some of that auto-regulation. Intra-abdominal, intrathoracic pressure, like we said, coughing, sneezing, straining, these things can increase intracranial pressure. Posture, head of bed elevation will decrease ICP. So you'll see with all these patients, we like the head of bed to be at least 30 degrees elevated. Temperature, brain temperature is usually about 1.5 to 2 degrees higher than your core temperature because of the metabolic rate. So we know fever's bad for the brain, and that can actually raise your ICP. Likewise, hypothermia, if we put someone in a therapeutic hypothermia, say after cardiac arrest, that will actually help lower intracranial pressure, and that helps with neurological outcomes. Blood gases, particularly the carbon dioxide levels in the blood, with hypercapnia, when we retain CO2, our blood vessels will actually vasodilate to increase blood flow and oxygen delivery to those neurons. So these are some things to take into consideration when you're caring for patients that might have an increase in their ICP. So what can cause increased ICP? Well, we have mass lesions. That would be your abscesses that can be found in the brain, tumors, hematomas, where, collections of blood, whether it's epidural or subdural, or hemorrhagic, such as intracerebral hemorrhages or subarachnoid hemorrhages. So those are mass lesions. AVMs can also, arteriovenous malformations, can also cause a hemorrhage and be a mass, or be a mass lesion by themselves if they get big enough, whether they rupture or not. Then we have cerebral edema or swelling. Brain tumors has vasogenic edema because the blood-brain barrier is no longer intact. So not only do you have the tumor, which is an increase in the mass, but you're also going to have swelling around that tumor. Hydrocephalus, which is interstitial edema due to rupture of the blood-brain barrier. So, we see increased amounts of cerebral spinal fluid, and the ventricles will enlarge. Traumatic brain injury, this is cytotoxic edema, where the blood-brain barrier is intact, but because of the injury to the cells themselves will be inflamed and will swell. And then brain inflammation, as in an encephalitis. That too is cytotoxic edema, so the cells itself are going to swell. And then we have any kind of metabolic insults. This can be prolonged downtime during cardiopulmonary arrest. This can be heavy metal exposures, those kind of situations. Now we have primary versus secondary injury. Now, primary injury is the damage that occurs at the time of the injury. That's due to either displacement, bruising, or damage to any of the three components. So it's, for instance, blunt force trauma or the impact from the motor vehicle crash. That's primary. There's not a lot we can do about it. So our focus is on secondary. The secondary injury is what follows the primary injury, and it can occur several hours to days, up to 72 hours after the initial injury. And then the primary concern when we're managing these situations is to prevent these secondary injuries that arise from, say, hypoxia, ischemia to the surrounding tissue that's already injured, hypotension, where we would have an increase in ICP because we're going to vasodilate to try to get more blood flow to the brain, swelling, or increased ICP. These are going to cause more damage to the brain than what the initial primary injury would have alone, and it can worsen outcomes. So what does it look like if somebody has an increase in their ICP? Well, we know that a change in your level of consciousness is the most sensitive. And it's not always going to be a decrease first. Everybody seems to automatically think it's a decrease. But what you may see is an actual increase in agitation or decreased attention span. Maybe they behave a little more aggressively. They're more irritable. You may see that before you start seeing that decrease in their LOC. So we're looking for that change in behavior, that change in level of consciousness. Changes in vital signs. We'll talk about those in a little bit as far as heart rate, respiratory rate and pattern, and blood pressure. Changes in ocular assessment findings, and I'm going to take you through some of those step by step. Decrease in motor function, a headache, or vomiting without nausea, and it's often projectile. So these are some of the things that we're going to see. Also in this little cartoon you have next to it, we also talk about changes in speech. Are they very much like a stroke? Do you start seeing dysarthria, where they're slurring their speech? Do you see aphasias or dysphagia, same meaning, where they either can't express themselves properly, so it's an expressive aphasia, or a receptive aphasia, or a global aphasia? Are they using a word salad? Those are types of things in speech that we look for. So change in level of consciousness, again, most sensitive and reliable indicator of a patient's neurological status. Anytime you've got an impairment in cerebral blood flow, then you're going to have a decrease in oxygen to the reticular activating system, which is deep in the midbrain. So this can interfere with the patient's ability to respond to his or her environment. It can be dramatic or it can be subtle. And it can be defined by their behaviors, as well as if we had them attached to an EEG, you'd see a change in the brain patterns, the brain activity patterns. A coma is your deepest level of unconsciousness. So there will be no response to painful or noxious stimuli. They'll have a negative corneal reflex. Pupils will be fixed and dilated. The swallow will be impaired, and the patient's cough will be ineffective, and patients will become incontinent to bowel and bladder. The EEG, if we have them attached to one, would be flat. It'd be absent or decreased neuronal activity. So one of the things we go by, and I'm going to show you what the Glasgow Coma Score system looks like. If you have a decrease in your Glasgow Coma Score of 2 points or more from the patient baseline, that's a significant change, and that has to be reported to the healthcare provider. So here's your Glasgow Coma Scale. And what we're doing with this is documenting the patient's level of consciousness. So we're assessing them in 3 areas. Eye-opening response is, they get 4 points for opening them spontaneously, say when you walk in the room. If you call their name, they open their eyes, that's 3 points for speech. They get 2 points if they open their eyes to a noxious or painful stimulus. If they don't open their eyes to any type of painful or noxious stimulation, they get a 1. We also look at their verbal response. 5, they get 5 points if they're oriented to person, place, and time, so oriented times 3. If they're alert but confused, they get 4 points. They get 3 points if they're awake and they're using inappropriate words, like a word salad. 2 points is incomprehensible sounds, moaning, groaning, but they're not really saying any words. And 1 is no response. A patient that's intubated usually gets 1 point. Motor responses, they get 6 points if they can obey commands, simple commands, hold up 1 finger, wiggle your toes, raise your eyebrows, those kind of things. They get 5 points if they move to localized pain. So if I give them a noxious stimulus, they'll use the other extremity and push the person away, okay? 4 points if they withdraw from pain. And then 2 and 3 are abnormal reflexes. So 3 is abnormal flexion, or what we call decerebrate posturing. 2 is abnormal extension, which is which we call decerebrate posturing, and 1 is no response. So the lowest you can get on this scale is 3, the highest is 15. So Cushing's reflex. This is a late sign of increased intracranial pressure. So it happens when we have so much pressure in the cranial vault that there's extra pressure placed on the thalamus, the hypothalamus, the pons, and the medulla. And with Cushing's triad, we have a change in our vital signs. We're going to see bradycardia, so heart rates in the 40s, 50s, hypertension with a widened pulse pressure. Blood pressure can get up in the 250, 300, but it'll be a very wide pulse pressure. So diastolic could be 60, 50. It'll have an irregular respiratory rate and pattern. And they go through very different types of changes in their respiratory pattern. Initially, they may hyperventilate in an effort to blow off CO2 to decrease some of the blood volume in the brain. But then they can, if they're not intubated and on mechanical ventilation, you can see these changes. But once they're intubated and put on mechanical ventilation, it's not so easy to pick up some of these irregular patterns. They'll have an inability to regulate body temperature. And a lot of times they will have a fever, and they'll be hyperthermic. And their Glasgow Coma scale is usually anywhere from 3 to 5. Occurs primarily in the brainstem due to that increased pressure and brainstem herniation. So it's forcing pressure in a downward way so that we can have central herniation, which can cause death, which would basically mean the pressure is so great that it's forcing the brainstem through the foramen magnum, where it connects with the spinal cord. So this is an emergency situation. It is life-threatening. We have to control the ICP and notify the healthcare provider immediately. So there are some ocular signs for an increase in ICP. So one of the, whoops, let me go back here. One of the first things we look at are cranial nerves 3, 4, and 6. 3 is pupillary dilatation. So when cranial nerve 3, as you can see here, when you've got a mass lesion here, say we have an epidural hematoma, then it's causing increased ICP. It's going to displace or push brain tissue out of the way. And when it does, it causes this part of the cerebrum to herniate. This is a supratentorial herniation. It's going to herniate over that uncus, or so we'll call it an uncal herniation. This compresses the third cranial nerve. So now, remember your eyes are ipsilateral, so it will be on the same side as the lesion. So this is the patient's, we'll say, left side. So the left eye would be dilated and sluggish to react. You may also see inability to move the eye upward, and you may see ptosis or sagging of the eyelid. With 4 and 6, patients will have blurred vision, double vision, diplopia, or changes in their ability to do their EOMs. With central herniation, you'll see sluggish but unequal pupils, but both will be dilated. With uncal herniation, it's a unilateral dilated pupil. And then if you were to pull out a otoscope, what you would see, or excuse me, ophthalmoscope, otoscope's your ears, ophthalmoscope, you would see what we call papilla edema, okay? So you would see a blurred disc margin here, and you'll see the edge of the swelling. So you would see the eye changes as well. Now, as nurses, we don't routinely do that, but this up here is enough to get our attention. We also look at cranial nerves 5 and 7. The corneal reflex, if that's absent, and to test that, we usually just take a little cotton swab and we'll, just touch the cornea, and they should blink, or they should blink to threat, okay? If that's absent, then we want to make sure we're doing good eye care to prevent drying or corneal abrasions. So we'll usually put some type of ophthalmic ointment on the eyes and make sure that they're closed. If for some reason they're swelling or the eyelids can't shut, you may see us tape them shut, or put little eye pads or something over them just to protect the cornea from any abrasions. We also can do 2 other tests if the patient is unconscious. If they're conscious, they'll override these. But if they're unconscious, and especially with the doll's eyes, if there's no cervical injury, we can do the doll's eyes or oculocephalic test. These are tests that also were done at the bedside to assess for possible brain death. So what we do is we hold the patient's eyes open, and we start in that neutral position here in the middle, and you hold the patient's head and you quickly turn it to one side and then back to the middle. And if the cranial nerve 5 is working, what you'll see happen is the eyes should move in the opposite direction that you turn the head and then go back to midline. If they stay midline or they roll upward or downward, it means that the brain has no idea where the head is. Because if you think about it, anytime you turn your head, your eyes automatically adjust to the way your head is positioned. The other thing we do is ocular vestibular, and this is your cranial nerve 8 that we're checking. And with cranial nerve 8, that's your balance. And what happens here is we take about 20 cc's of sterile saline. We take an IV catheter, take the needle out, and we'll put the catheter into right close to the eardrum, and we'll slowly inject that saline. And while we hold the eyes open, what should happen if everything's intact is you'll see some nystagmus, and then the eyes should drift toward the ear that we injected the iced saline in. So we call these cold chlorics. If the eyes stay put, they don't move, there's no nystagmus, it means that the brain didn't pick up any kind of stimulus. Now, if you're awake and alert and intact, and we do this test, makes you extremely dizzy. So you're going to have severe nausea and probably projectile vomiting. It's not a pleasant test. So if anyone's ever had vertigo and they do this test, make sure you got the trash can close by. Now, the next thing we're going to do is motor strength. Now, in a conscious patient, we just ask them to follow commands, and we test each side simultaneously. So you take both hands and tell them to squeeze your hands as strong as they can, push you away, pull away, the push-pulls that you do on your head to toes. We can look for a palmar drift where we have them hold both arms out, close their eyes, and have their palms up. And if one side's a little weaker, one side will drift, the weaker side will drift downward. Now, if you're conscious, you automatically adjust, so we can't pick it up. So they have to have their eyes closed so they're unaware that they're drifting. And then we ask them to lift their legs. And we lift one leg at a time to the count of 5, okay? And we look to see how long they can hold that position. If it's an unconscious patient, then the first thing we do is just look at their spontaneous movements to noxious stimulation. Are they moving both sides equally? Do they have equal strength when we try to move or do anything with them that stimulates them and they work against us? We look at resistance to passive range of motion. And in an unconscious patient, we never ask them to squeeze our hand, because there's a thing called a palmar reflex that's present in the neonate. And what happens, families come in, they say, oh, if you can hear me, let me know you hear me, squeeze my hand. Well, they'll squeeze, and the family member says, oh, they know I'm here, they're in there. Well, maybe, maybe not. The only way to really know is say, okay, let go my hand, and they won't let go. Okay, they'll just squeeze harder. So that's never a good way to assess a patient's ability to follow commands if they're unconscious. We want to say, give me thumbs up, wiggle your toes, give me something that I know is not a reflex. We also look for contralateral hemiparesis, or loss of sensation, or hemiplegia, loss of motion, on the opposite side. So contralateral, opposite side from where the lesion is. So if they have a right-sided brain injury, I'm looking to see if there's any loss of sensation or movement on the left. If it's a left brain injury, I'm looking for losses on the right. And then remember, we talked about abnormal posturing in the Glasgow Coma Scale. Well, here's a couple of pictures. The one on the top is decorticate posturing. That's abnormal flexing toward the core, decorticate, okay, away from the core. So, or excuse me, towards the core. So decorticate posturing is a little bit higher level than decerebrate, the picture on the bottom. Decerebrate is abnormal extension of the arms away from the cerebrum. So it's a lower level of functioning. It's a little worse. So it's worth 1 point where decorticate is worth 2 points. But both are abnormal. If your patient was decorticate posturing and now they're decerebrate posturing, that's a call to the physician. They've worsened. But if they're decerebrate posturing and now they're decorticate posturing, then he's actually a little bit better. You don't need to call the physician for that. Now, every now and then, you know, patients don't read the books. You might have decerebrate on one side, decorticate on the other, and yes, you can have that. And it's just swelling deep within inside the brain. Headache and vomiting. A headache is due to the compressions of the intracranial structures, the arteries, the veins, the cranial nerves. A lot of times they'll complain of it being a continuous headache, but it's worse at night because the head position is down, so their ICP goes up. It'll be accentuated by any kind of straining, movement, or agitation. With the vomiting, it's no nausea. In fact, it can be completely unexpected vomiting, and it will be projectile. And that's related to pressure changes in the cranium that will stimulate the vomit center in the brainstem. Now, monitoring of ICP and cerebral oxygen, there are some indications for ICP monitoring. And really, we're looking at patients that are at risk bar or who have evidence of an increase in their ICP. So strokes, tumors, abscesses or infections, encephalitis, traumatic brain injury, anybody that has got a Glasgow coma score less than 8, because coma, once a patient has a Glasgow of 8 or less, they're considered to be comatose. And if there's an abnormal CT or MRI that has the healthcare provider at concern. Now, normal ICP, like we said, is 5 to 15. Once ICP is 20 millimeters of mercury or higher, it is going to require treatment. Now, our gold standard is the ventriculostomy, which will allow for monitoring and drainage of your cerebral spinal fluid to help control the ICP. So here in this picture, this is the ventriculostomy that actually sits in the fourth ventricle. So this one is not actually in the correct position, but it will allow for us not only to monitor ICP, but we can remove this. With an intraparenchymal fiber optic catheter, that goes into the brain tissue. That only allows us to monitor. It doesn't allow us to remove any CSF. Same thing with the epidural transducer, and it's probably the least accurate. So you get kind of a trend. Subdural catheter, the same thing, more of a trend. And again, we can't remove CSF. And then the subdural bolt, again, a pressure, but it's not going to let us do that. And none of these would be, most of these are going to be placed on the non-dominant side. And we assume most people are right-handed unless we know otherwise. So if they're right-handed, we usually go on the left side, and we go more, we kind of draw an imaginary line from the outer canthus of the eye to where the top of the ear, and we come up and we kind of meet up on the top of the skull. So pretty much the general area of placement is where we see this fiber optic port here. And this will be attached to pressure tubing like we use with hemodynamic monitoring. And it will be put to a transducer. The only difference is it doesn't have a continuous flush because we don't want to put any fluid into the system. And the nurse can get a continuous monitoring of this and can drain as needed, or the physician will give specific orders as how they want us to manage the catheter. But the goal is to keep the ICP less than 20. So here's our external transducer here, and we line it up with the foramen of Monroe, which is about at the tragus of the ear, okay? We usually put the drainage system is this little manometer here. We put the 0 at where the transducer is, and because we want it to drain if the ICP gets over 15 millimeters of mercury, we usually there's usually a measurement here, and we put the top of this at 15. So if we leave it to continuous drain, anytime that a patient's ICP goes over 15, you'll see some drops of CSF. And CSF should be clear, should be colorless, should be odorless. And so if we see a little pink or we see blood in there, that might be from like a subarachnoid hemorrhage, so that there may be blood in the CSF, or from a traumatic subarachnoid hemorrhage. Does have to be re-zeroed anytime the patient is repositioned. And again, we don't have a continuous flush. Measuring ICP is a mean pressure. We don't read a systolic and a diastolic, we read a mean. So we usually, and we read it on the lower scale of 0 to 20. If it's a little more elevated, we can read it on a 0 to 40 scale. If we're draining continuously, we have to close the drain and keep it closed for about 6 minutes in order to get an accurate reading. And we will record the waveform strip with any of our other pressure. So here, like, you have your ECG, you have your arterial pressure, you have a CVP pressure, this is respiratory variation. And then down here, you'll see your ICP tracing, okay? And obviously this one's high. Okay. Now, CSF drainage, when we are doing this, we can only do it with a ventriculostomy. Again, MD will give us specific orders, and we'll monitor the amount of CSF hourly. If we take off too much or we take it off too fast, the ventricles can collapse, and you can have a subdural hematoma, or it can cause herniation. So you do have to pay close attention to this. Now, the biggest complication from ICP monitoring is going to be infection. So not everybody, but some physicians will give prophylactic antibiotics, something that's kind of broad spectrum that would cover staph and strep, things that would be on the skin. And we know there's a higher risk if we have to monitor for more than 5 days, if we're using the ventriculostomy, because again, that's directly into the ventricles. If there's presence of a CSF leak, or if there's a concurrent systemic infection, then that could get into the cerebral circulation and get out into the CSF. So infection's the one that we worry about the most. Now, we know ICP, the swelling usually peaks at 72 hours and then starts going down. So we do try to get these out within 3 to 5 days, because beyond that, it's usually not going to be needed. Things should have stabilized, or we've chosen a different way of intervening, such as a craniotomy, craniectomy. Now, one of the complications that we see in head injured patients and patients with an increase in ICP is diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Now, diabetes insipidus is a decrease or a lack of antidiuretic hormone that acts in the kidneys. So the signs and symptoms we see with diabetes insipidus is, think about the polyuria, the diabetes. These patients will have a very high urine output. They can put out more than 200 milliliters an hour for 2 consecutive hours in the absence of a diuretic. Because remember, on these ICP patients, and we'll talk about how we manage some of this when we are talking about brain injured patients, we keep them on the dry side. So if they're, every now and then we may treat them with mannitol to bring down the ICP, or with Lasix to bring down the ICP to get rid of excess volume, but we can overdo it. But in diabetes insipidus, if we didn't give one of these agents and the patient's putting out urine more than 200 milliliters an hour for more than 2 consecutive hours, then we need to screen them for DI. So what you'll see is hypernatremia. Their sodium will be greater than 145 milliequivalents per liter. They'll have a low urine osmolality. It'll it's pretty much just water that they're losing. Okay, remember that's what antidiuretic hormone does. It controls the reabsorption or excretion of just the water in those collecting tubules of the kidney. You'll have a low urine specific gravity. It should be less than 1.005, okay, which is pretty much water. And then increased serum osmolality can be greater than 320 milliosmoles per liter. With syndrome of inappropriate antidiuretic hormone, inappropriate meaning I have too much antidiuretic hormone that's been released, then I hold on to water. Antidiuretic, I hold on, antidiurese. So with these, I get a decreased urine output. So I'll see a dilutional hyponatremia, a high urine osmolality, because I'm not going to be putting out that much urine, and a high urine specific gravity, because it's going to be very concentrated. So the osmolality and the specific gravity will be elevated. But my serum sodium and my serum osmolality will be low. Again, the serum osmolality is low because I'm hanging on to too much water and I've diluted out my sodium, which is one of the big determinants of serum osmolality. So make sure you know the difference. The way we treat diabetes insipidus is we usually give vasopressin or usually sub-Q. We can give it if it's going to be long-term, we can give it intranasally, but we usually give it sub-Q. And once we give them the vasopressin, they stop. Okay, that should stop it. And then I replace cc for cc of urine output with a hypotonic solution like half normal or quarter normal saline, depending on what my serum sodium is. So if my patient put out 600 milliliters of urine this past hour, then this coming hour, I've got to, over the next hour, I've got to give them 600 milliliters of, say, half normal or quarter normal saline. So a lot of times it helps to have a really good either antecubital or a triple lumen type central catheter. If it's syndrome of inappropriate antidiuretic hormone, I can give diuretics and I can put them on fluid restriction. And that usually will help. Both of these should be transient if it has to do with the cerebral edema and the swelling in the brain itself. So if it's due to increased ICP, within 3 to 5 days, it should go away on its own. Now, cerebral perfusion pressure, that's the pressure needed to ensure blood flow to the brain. So when we look at this, we talk about cerebral perfusion pressure being equal to the mean arterial pressure minus the ICP. So normal is usually about 60 to 100 millimeters of mercury. So if I do the math, you know, mean arterial blood pressure, it's going to be your diastolic plus 1/3 times the systolic minus the diastolic, or I like to do it this way, the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3, okay? So an example, if my systolic blood pressure is 122, my mean arterial pressure is 97, my ICP is 12, so mean minus ICP, my cerebral perfusion pressure is 85 millimeters of mercury. So it's critical to maintain that map anytime ICP is elevated. So even though I might have a good blood pressure there, say for instance, if my ICP was 20, then that automatically drops my, say, 97 minus 20, that's 77. I'm getting a little on the lower side. If my ICP was 30, that would make it 67, and we would be in trouble. Okay, we're getting to that really low part of CPP. So we always want to pay attention to what that mean arterial pressure is, because if my ICP is high, it'll decrease the amount of blood flow to the brain. Other factors that affect cerebral blood flow, cardiac arrest for obvious reasons, okay. It requires CPR, and that's the only way they're getting blood flow. So patient can have a global ischemic event. Same with respiratory arrest. If the patient stops breathing, you know, often that leads to the cardiac arrest. A systemic hemorrhage, where the mean arterial pressure is so low that I lose my ability to auto-regulate in the brain perfusion, and so I don't have good cerebral blood flow. Diabetic coma, encephalopathies, infections, and toxicities. All of these can affect cerebral blood flow so that patient can have permanent injury from ischemia. Regional would be more to one specific part of the brain. General meaning the entire global part of the brain. So regional would be trauma, closed head injury, tumors, cerebral hemorrhage, because it's usually confined to one lobe of the brain, or a stroke. So how do we manage ICP? Well, first we identify and treat the underlying cause. And then it gets to your airway, breathing, circulation. So we have to maintain a patent airway, ensure adequate oxygenation, whether that means intubating and putting them on a ventilator, or just supplying exogenous. It depends on how well they're breathing. If they need to go to the operating room for surgical interventions to repair any injury or remove tumor, then that's what we'll do. We want to manage cerebral edema, and we do this through diuretics and corticosteroids, and then patient positioning. And if we have to do ICP monitoring, we'll do that. Corticosteroids are only going to be used in tumors. They're not going to be used in traumatic brain injury. Drug therapy, and we'll talk about some specifics there in a minute. Nutritional therapy, remember they are going to be hypermetabolic and hypercatabolic due to the injury. So if they're in pretty good nutritional status when they come in, we'll usually start nutritional therapy within 3 days and then try to reach their full nutritional replacement by day 7 post-injury. Now we prefer to use the gut. So if the gut's working, we use that. So tube feedings are appropriate. If that's not appropriate, or the gut is injured because of multi-system trauma and unavailable, then we will have to go down the parental route and use central parental nutrition, or TPN. Fever, we already talked about fever being bad for the brain. It's usually a central fever, which means there is no spike. It just goes up. There's no normal fever curve. And it usually doesn't respond to acetaminophen. We'll go ahead and give them acetaminophen. We'll do blood cultures to rule out any possible infection, but 9 times out of 10, it's a central fever. So they'll probably need a cooling blanket to help control it, but you cannot allow them to shiver, because that actually drives up the metabolic rate of the body and the brain and increases demand for oxygen. And we may already be having difficulty getting there. So we just can't let them shiver. Agitation and pain, we're going to use short-acting opioids and avoid benzodiazepines because they take too long to clear the system. Shivering, we already talked about not to allow it. And then seizures, anti-epileptics are used for that, whether it's Keppra or Dilantin or fosphenytoin. Some physicians will give that prophylactically, some will not. Now, if a patient had a witnessed seizure, say when they came in the ER or at the scene by EMTs, then they will definitely be put on those prophylactically to prevent any other seizures. But if they haven't had a seizure, some physicians won't start it unless they have to. So that's a maybe, maybe not. But we do know that they're at high risk for seizure with an increase in their ICP and from traumatic brain injury. Like I said, drug therapy. For all IV solutions and IV piggy bags, we do not want any D5 water or sterile water. We only want it mixed in normal saline. Because if we give them D5 water or sterile water, that can cause cerebral edema. So we don't want any of that. Should just be normal saline, something isotonic. Mannitol is an osmotic diuretic. So when we're giving that drug, we have to make sure that we're monitoring the serum osmolality and the serum sodium so that we don't dry them out too much. Loop diuretics, your Lasix, your Bumix. So we're going to watch potassium very closely and urine output. hypertonic saline or 3% saline. We can also use to control ICP. That's a hypertonic. So when we put it in the blood vessel, it's going to pull fluid into the vascular space. Again, we have to be real careful with that. We aren't going to give more than 50 milliliters an hour. And then after 3 hours, we're going to check a serum sodium and we're going to see how the patient's responded. Because it is so hypertonic, patients should have a central line because it's very irritating to the veins. Corticosteroids, Decadron is usually the go-to drug, but again, it's usually for decreasing the edema around the tumors. We do not give in traumatic brain injury because it has not been shown to really help. It's not very effective in cytotoxic edema. Anti-epileptics, like we said, depends on the provider and what's going on with the patient. And barbiturates or a continuous propofol infusion may be used to medically induce a coma. And when we do this, the patient has to have continuous EEG monitoring. So we'll have the guys and gals come in from neurodiagnostics, set them up, and they'll have a continuous EEG running, and the physician will order a burst suppression frequency. So they want to see pretty much flat lines on everything, but every 10 seconds, we want a little burst of brain activity. So we'll just see boom. And you don't have to be certified to do this. The text can show you on the screen, which areas at 10-second strip so that you know where to be looking to monitor that. But this, again, you might see this used for subclinical seizure management. You may also see it used in patients with increased ICP, and it's just trying to rest the brain and decrease, oxygen demand. So I don't need as much blood flow up there. So that's one volume that I don't have to worry about. Nursing management, Glasgow Coma Scale. We're going to do this every 1 to 2 hours for the first 24 to 48 hours. And then depending on how they're doing, we will keep it. Anytime we do the vital signs, we do the Glasgow. So you're going to be doing that regardless. If it's a stroke patient, we do an NIH on admission, and then we won't do a full NIH every hour, but we'll do a modified NIH every hour. But when we're doing these neuro assessments, we need to make sure that we're looking at pupillary responses as well as cranial nerves, okay? Vital signs, like we said, every 1 to 2 with the neurochecks. Respiratory pattern, we're gonna be observing for central neurogenic hyperventilation or cluster breathing or chain stoke type patterns. Proper positioning, we want head of bed no less than 30 degrees of elevation. We want to avoid hip flexion, so we don't want them, say, in a high Fowler's position. 30 to 45 at the most is what we want on them. And we want their head in a neutral position, especially if they've been intubated. We don't want any tape obstructing jugular vein, and we don't want them, kinking their head to one side so that the veins can't drain the head. We don't want anything, we avoid the hip flexion because we don't want to increase in intra-abdominal pressure, as that can raise ICP. We're going to monitor INO closely, looking for any signs of diabetes insipidus or SIADH, and then we monitor for insensible losses as well. If they're having sympathetic storms, for instance, they can lose a lot of volume from just extreme sweating, okay? Maintain cerebral perfusion pressure. We want it greater than 60 millimeters of mercury. Otherwise, once it gets, less than 60, we're looking at severe ischemia. If it's getting down to 30 or less, then that's neuronal death. They'll die from that, and that's not going to come back. Manage pain and anxiety. We talked about short-acting opioids, morphine, fentanyl, Diprivan or propofol for anxiety, and avoiding benzodiazepines. Protect them from injury. If they're moving one side of their body well or both sides of their body pretty well and they're pretty strong and they're aware of noxious stimulation, if the lights are on but nobody's home, in other words, they're very agitated and they're thrashing about, they can hurt themselves on the bed rails, they'll extubate themselves if they're on ventilators, pull out catheters, those kind of things. So we want to make sure they don't hurt themselves. If we're concerned about seizures, obviously we'll have seizure precautions in place. And then psychological support. A lot of times this isn't so much for the patient as it is the family. This is usually a crisis situation, and it's going to be very overwhelming for the family as they try to take in all this information. And of course, it looks absolutely scary and horrible and something out of a bad movie that they've probably seen. So it does require that you be patient with them. They may ask you the same question over and over because they just can't process all this information that's coming at them. So help keep them focused and setting their priorities of what needs to be done, and reassure them, and never take away their hope. But knowledge is power, so we educate them in small amounts that they can take in and answer the questions that they ask. And if they need spiritual support, obviously, you can get someone to help them with that. Any questions that you have, please reach out to me or other faculty members, and we'll be happy to help you. This is all covered in Chapter 56 of your Lewis textbook, and I look forward to seeing you around on campus. Thanks, guys.